Hello, everybody, and welcome. Thank you so much for joining. We will give a couple more minutes for some people to filter in, and then we'll go ahead and get started. If you're just joining us, thank you so much and welcome. We'll give just another minute or so for some more folks to join, and then we'll go ahead and get started. All right, so it is 2 minutes past the hour, so we will go ahead and begin today's webinar. So good morning, everybody, or good afternoon, and welcome to today's webinar, which is hosted by Hepatitis Delta Connect. My name is Beatrice Sovich. I'm a Public Health Program Manager at the Hepatitis B Foundation and the manager of Hepatitis Delta Connect. So thank you so much for tuning in today. Today's webinar will be focused on the epidemiology and screening patterns for hepatitis delta virus in Utah in the United States over a 22-year period. And we'll have the opportunity today to hear from Dr. Melodie Weller at the University of Utah, who will share some of her recent research in this area and who will underscore the need to increase hepatitis delta testing and screening. So we look forward to a great presentation. Next slide, please. Thank you. So before we get started, I would just like to remind all participants that during today's webinar, all audience members are muted. We encourage you to use the chat feature to let us know who you are and where you are joining from. And if you have any technical challenges, please indicate your issue using the chat box and we will address it as soon as possible. If at any time during the presentation today you have questions for our speaker, you can feel free to enter them into the Q&A box, and questions will be addressed by Dr. Weller at the conclusion of the presentation. This session is also being recorded, and slide presentations will also be shared following the webinar. Next slide, please. Thank you. So just before we begin the presentation, just a quick background about Hepatitis Delta Connect. So Hep Delta Connect is a dedicated program of the Hepatitis B Foundation, and it was established in 2016 for the explicit purpose of raising awareness about hepatitis delta and promoting diagnosis, screening, research, and linkage to care, as well as providing support for individuals who are living with and affected by hepatitis delta through a wide variety of channels. These include email and phone consultations, social media, newsletters, blog posts, a website, and focused advocacy and webinars such as this one. We also run hepatitis delta focused events, and we lead hepatitis delta public health research projects. We are hoping to continue to build and expand our programming throughout 2024 and beyond, and we will keep you posted about these developments and further opportunities to get involved. Next slide, please. Thank you so much. So today we are excited and honored to be joined by Dr. Melodie Weller, who is an assistant professor of pathology at the University of Utah School of Dentistry in the United States. Dr. Weller leads a research lab that investigates viral-mediated mechanisms of chronic autoimmune diseases, as well as autoimmune-associated lymphomas and global infectious disease modeling. And she has a lot of experience in studying the interactions between viruses and host immune responses and their implications for disease prevention and treatment. We're really excited to hear from Dr. Weller today and are grateful to her for joining us. Again, we invite any audience members to put any questions that you may have in the Q&A box as they arise, and they will be addressed at the conclusion of the presentation. And without further ado, I invite Dr. Weller to begin the presentation. Thank you so much.
Okay, so you can see my slides okay?
Yes.
Yes? Okay, good. Okay, so thank you for the introduction, and thank you again for giving me the opportunity to speak about one of our recent publications today. So my name is Melodie Weller, and I am at the University of Utah in the School of Dentistry. And as mentioned, I run a research lab that studies hepatitis delta virus in multiple contexts, epidemiology, as well as the discovery of HDV in patients with Sjogren's disease. And so today I'm going to talk about a recent publication from my team looking at, or titled, The Growing Awareness, Limited Testing and Screening Bias for Hepatitis Delta Virus in Utah between 2000 and 2021. Oops. So an overview for today's talk, I'm going to go over a retrospective study where we've evaluated hepatitis B virus and hepatitis D virus epidemiology over a 22-year period. Using electronic health medical records from the University of Utah UHealth system to evaluate both our HBV and HDV patient populations and to better understand the prevalence and testing profiles within these patient populations. So after I share the findings of the study, I also will compare and contrast what we're finding with other published studies looking at HDV epidemiology within the United States and in general healthcare settings. I'll also talk briefly about implications of the current AASLD HDV testing recommendations. And most importantly, I want to shed light on why we really need to improve HDV epidemiology for the capacity to really detect changes in HDV transmission patterns around the world. And this is even more important now that we've been seeing a growing number of HDV-like sequences identified across the animal kingdom and in humans. So a little bit background on HDV. As we all know, it's a rare infectious disease that can occur as a co-infection with hepatitis B virus. So HDV is the only satellite RNA known to infect humans and have an associated disease. And individuals that are co-infected with HDV tend to have a more aggressive progression of hepatic disease, including increase in hepatocellular carcinoma as well as cirrhosis. But despite our vast understanding of how significant a co-infection is to the HBV patient population, HDV is understudied and underreported. So there's limited testing and limited tracking of those positive cases in the United States. And so what I hope to impress upon you today is the crucial need for not only more comprehensive studies, but collaborative studies on a national and international level to really understand the HDV transmission profile and overall epidemiology, but also to help us improve current testing protocols. So the current testing recommendations in the United States are outlined by AASLD. And in this, it's a risk-based assessment for testing. Individuals who are HBV positive are then evaluated for select risk factors, including being born in regions with noted high levels of HDV prevalence, men who have sex with men, persons with a history of IV drug use, co-infection with Hep C or HIV, individuals with multiple sexual partners or history of STIs, or HBV positive patients who have elevated ALT or AST with limited or low level detection of HBV DNA. So individuals who have these risk factors are then recommended for testing. And the recommended testing protocol is to first test for HDV antibody, usually using a total antibody detection of both IgM and IgG. And then if positive, then going on for further testing to detect HDV RNA. But what we found for our counterparts to AASLD in Europe and in Asia is that these other organizations have changed their recommendations for HDV testing to include testing for co-infections in HBV patients, including HDV, Hep C, and HIV. So while this increased testing recommendation is found in Europe and Asia, our current AASLD guidelines do not feature that, though there is discussion of having an updated testing recommendation. This is our current recommended protocols. So hepatitis B virus is a nationally notifiable disease, and it has been for multiple decades. And so what this means is that if anybody or a patient is test positive for HBV, that case is reported to on a national level. This is not the case for hepatitis delta virus. It is a non-reportable disease on a national level. But a recent publication from my team, we went through and evaluated the reportable status for HDV on individual state and territories. And we actually found something very interesting. We found that 55% of state and territories do require reporting of HDV cases on a local level. And this would be defined as individuals who are tested positive for HDV directly or any type of viral hepatitis. So of the 55% of states and territories that require reporting, there was a little bit more ambiguity on what tests they require for that reporting. And so, and we found that there was a limited availability and or access to HDV case definitions when we approached this study. And so what we found was that a majority of the states and territories would accept any HDV positive test, so antibody, RNA, or antigen. 19% of the states that require reporting only required reporting of HDV positive antibody tests, and 23 required reporting of or would accept HDV antibody or RNA positive tests. So the Council for State and Territorial Epidemiologists, or the CSTE, is currently working on an HDV definition or case definition, and we would hope that once that is approved and released, that would increase the availability and direction of not only how to report, but what tests to perform within the HDV patient population in the United States. And that may also favor increase in reportable status, hopefully. So the limited surveillance and tracking of HDV in the United States has really significant impacts on our understanding of the epidemiology of this rare infectious disease. It has significant impact on how we implement effective preventative therapies as well as treatment strategies. So just the capacity to recruit patients for clinical studies is challenging. But also because we don't actively test and track HDV in the United States, that if there are any changes in the transmission pattern, it will most likely go unnoticed for some time. And so this study was designed and performed to really help fill in those knowledge gaps and to help us better understand the epidemiology and the changing trends in HDV, and specifically within the University of Utah health system. So to perform this study, we looked at a 22-year period and evaluated the electronic health records for patients between 2000 and 2021 that were patients at University of Utah U Health System. And in this, we defined our HBV cohort and our HDV co-infected cohort. So as you can imagine, working in a natural healthcare setting, that there may be incomplete records or inconsistencies in the diagnostics of HBV and HDV. So for the HBV cohort, we identified patients who were positive for HBV surface antigen, or they were positive or had at least 2 or more ICD-9 or 10 codes within their medical records, greater than 6 months apart, or patients who may have had a more incomplete profile where they had at least one ICD or code and another positive test for HBV, such as HBV DNA or HBe antigen test. And so that was how we defined our HBV patient population over the 22-year study. And for the co-infection, we found that HDV antibody positive patients, as well as patients who had at least 2 or more ICD codes over 6 months apart, and then also some more incomplete files where they may have at least one HDV ICD code and another type of positive HDV test, such as HDV RNA or HDV antigen. And so in doing this, we're able to define our 2 patient cohorts within the University of Utah UHealth system. So to start out, we identified 1,962 HBV cases within our patient population, but of those, only 435 showed evidence of being tested for HDV within the UHealth system. And so this is a 22% testing rate, which is actually higher than we normally see published for other studies in the HDV epidemiology within the United States, but still missing 78% of those HBV cases that could be potential carriers for Delta. So of the 435 patients that underwent testing for HDV, we found that 36, which is 8.3%, had at least one positive test for markers of HDV. So this is a little bit higher of a positivity rate than we normally see, and this may be due to multiple factors. We are testing at a higher rate here in Utah. And also we have a national reference lab, ARUP, that is just down the road and associated with the university, which increases the ease of ordering tests, performing tests, and also most likely the education about what tests are available. So overall, our patient population for HDV co-infections was 62 over the 22-year period. So this was 36 patients that tested positive for HDV markers, and then another 26 that were identified through ICD codes within their electronic health record system. So overall, we found that that was about a 3.2% prevalence, but due to the significant lack of testing across the entire HBV patient population, missing almost 80% of those potential carriers, I strongly feel that the HDV prevalence noted here is most likely highly underestimated. So looking at the overall cases over the 22-year period, so here is HBV cases starting from 2000 to 2021. We see a steady case or a steady level of HBV cases being identified. We do see an initial uptick of HBV cases increasing in the early 2010s. This is most likely due to significant increased testing of prenatal patients for hepatitis B virus around this time point. Looking at the same profile within HDV tests, so here from 2000 to 2021, the blue bars are the number of HDV tests that were performed, and the yellow is the number of those tests that came back positive. So what we see here is that there is a more recent steady increase in the amount of patients being tested for HDV. Again, starting in around the 2010s, we see a significant increase in the amount of tests performed. This was also around the time where we started to see more tests for HDV becoming available on the market. And within the last 5 years, so from 2017 through 2021, we did see a very significant increase where about 40% of our HBV patients are now being tested for Delta. So on a positive note, even though we have an overall lower level, we are seeing a significant uptick in really testing the HBV patients for potential HDV co-infections. The other thing we noted is that as testing increased for HDV, we did see a significant increase in the number of cases detected. So here on the y-axis, we have HDV positive tests, and here on the x-axis, we have the total tests run. And so as we see an increase in the total testing for HDV within the HBV patient population, we are detecting more cases. And so this goes in line with other studies that have been published recently looking at reflex testing, where if you increase the testing for HDV, we do tend to detect more cases and really identify those patients that may have previously been gone undetected of having an HDV co-infection. So this is very promising that the numbers are starting to increase as the way they are. Looking at the overall demographics in the patient profiles, while it wasn't significant, we did start to see an increase of female patients relative to male patients. And this is kind of in contrast to what we normally see in publications, where we do commonly see an increase or a higher level of males, both in the HBV and the HDV co-infected groups. We also did see that overall the age was slightly less at the age of diagnosis for these HDV co-infected patients. Looking at the liver enzymes and other markers, we were seeing that the HDV co-infected patients tended to have higher levels of albumin, bilirubin, as well as ALT. And while not significant, we did see an increasing trend of AST and ALP within our HDV co-infected patients. So this kind of follows the trend that we normally see in publication for having elevation of these liver enzymes within the HDV co-infected patient population. We also started to notice an interesting trend within the race and ethnicity composition between our HBV cohort, the patients that were tested for HDV, and those that were testing positive for HDV. So here we have the race and ethnicity for our HBV cohort, and what we find is that the most prominent group is the white population, followed by an Asian population of about 22%. But what was interesting is when we looked at which of those patients or what population of those patients were actually tested for HDV. And what we found were two interesting features. First off, the white population within the HBV patient cohort were less likely to be tested for HDV, and the same profile was found within the Hispanic population. But the Asian, Black, and Hawaiian Pacific Islander populations within UHealth tended to be tested at a higher rate for HDV than their composition within the HBV patient population. So this was really interesting, but this trend really didn't follow through as we were looking at the composition of the race and ethnicity in those patients that test positive for HDV. And so looking at this in odds ratio, again, we see a decrease in testing overall for HDV within the white population and the Hispanic population, but the Hawaiian Pacific Islander, Black, and Asian populations were being tested at a higher frequency for HDV. When we looked at whether the testing increased the odds of testing positive, we found that there was really no connection between the testing profile and the race and ethnicity composition of the patients that tested positive for HDV. So at this point, we don't understand really what is the underlying drivers for this bias in testing for HDV within the HBV patient population, but we're hoping to look at this again in a larger patient cohort to see if we can get more of an idea of what may be driving this. Oops. We also found that patients who were tested for HDV were more likely to be tested for other markers of hepatitis B virus. So as we can see here in the patients that were tested for HDV, we saw an overall increase in the odds ratio of their likelihood of being tested for other markers of Hep B. And so this might be an indicator of improved linkage to care and more of a focus on really defining what's the underlying cause of the disease and may lead to more likelihood of being tested for HDV. This didn't really follow through when we looked at those that were positive or those that were tested for HDV versus those that were positive. The testing profile were very similar. When we looked at the comorbidities for HBV and HDV, we did find that we saw an increased odds ratio of hepatocellular carcinoma, as well as hepatitis C virus within the HDV co-infected patient population. And within the Utah population, we did not see a significant increase in the HIV patient population that has commonly been reported elsewhere. So overall, this is in line with what has been previously published of showing an increased risk of hepatocellular carcinoma, as well as potential co-infections such as hepatitis C virus. So in conclusion of this study, first off, we found that there was limited testing within the HBV patient population of about 22%. So again, almost 80% of the patients or Hep B patient population within the UHealth system had lacked any evidence of testing for HDV. But on a positive note, there's an increasing trend of HDV testing within the HBV patient population. So over the last 5 years, we're seeing that testing rate within the HBV patient population of around about 40%. So it is improving. Our positivity rate of 8.3 within the HDV patient population is interesting. It's a little bit higher than what's commonly reported, especially for the United States. But again, this could be a factor of our connection between the University of Utah and a national reference lab, ARUP, that has well-established HDV tests available to the local community as well as nationwide. We are seeing that as we increase testing for HDV within our HBV patient population, we are detecting more cases of HDV. And this goes in line with other studies that have really shown as we increase or improve our testing protocols for HDV that we are going to be detecting more cases that may have not been caught until a later date, where you start to see risk factors such as hepatocellular carcinoma or other factors of cirrhosis surfacing. And also, we're starting to see biases within the decision of which patients are tested, which HBV patients are tested for Delta, but further studies are needed in a larger cohort, or at least different cohorts, to be able to understand the underlying what's really driving these biases on selection of who is being tested. But in the end, if we were to implement a reflex testing of all Hep B patients, such as what we see within the European and Asian liver organizations, I think that this would address any biases and better support the detection of HDV within the HBV patient population. So the limitations of our study, first off, in any single healthcare system, especially studying rare diseases, there is limitations on overall cohort size. And so this really pushes the need for larger scale studies, both national and international studies. So collaboration between different healthcare systems to really aggregate that data together will help us better understand the epidemiology profiles of HDV. As well, this study went over a 22-year period, and over that time frame, we saw a significant shift in the availability of tests, not only the availability, but the sensitivity of the tests that were available to test for HDV. So as we saw within the 2000 to 2021, we started to see more testing occurring starting in the early 2010s. And so that could have significantly impacted our overall evaluation of HDV epidemiology in Utah. So how does our study compare with other recently published studies looking at general populations within the United States? So here are 4 other studies. So first off, on the left-hand side, the percent of HBV patients tested for HDV. While we're at 22% overall for the 22-year study and 40% within the last 5 years, that is still a significant number of HBV patients that are not being tested for Delta. And again, looking at the other reports of testing rates in the other published studies, we're missing a significant amount of patients that could be potential HDV carriers. And so improving this testing profile will really help with early detection and early intervention. On the right-hand side here, we have the percent positive of those tested. And so again, most of the published studies were between 2 and 3% prevalence for that positivity rate for those tested, whereas within our study, we were at 8.3%. Again, this could be just due to the increase of testing within UHealth and also our connection with a national reference lab that is closely associated with the University of Utah. So this would also suggest that potentially as we increase HDV testing, that we may start to see these higher levels of positivity rates, at least initially, and it's just something to look for. So the risk-based assessment has been up for discussion for some time, but can lead to biases on who is selected. What we have found when we're going back through electronic health records is that some of these features that are risk factors and would be recommended for testing for HDV are challenging to detect within medical records. Specifically, only within the last few years has UHealth been monitoring or recording immigration status in health records. And so some of this data is now becoming available, but going back in a retrospective study, it's a little bit more challenging. And so, but as I've talked about earlier, having an automatic reflex testing protocol in place will really overshadow or deal with any type of biases that are coming through the AASLD current testing guidelines. And so we hope that this will shift soon to recommend testing for all HBV patients to be tested for Delta. So the other reason why it's important for us to improve our HDV epidemiology and understanding of transmission patterns is the recent discovery of a significant number of HDV-like sequences found across the animal kingdom as well as in humans. And so over the last 10 years, there's been a significant number of HDV-like sequences identified across many different types of animals. And this is kind of where I started in looking at HDV. So as I mentioned in the start, I am at the School of Dentistry. And one of the primary questions I get is, if you're in the School of Dentistry, why are you studying HDV? And that is because a while back, my team identified hepatitis delta virus antigen and sequence within the salivary gland tissue of Sjogren's syndrome patients. So Sjogren's disease is a chronic autoimmune disease that predominantly affects females. It is currently classified as dry eyes and dry mouth, development of autoantibodies, and inflammation within the salivary gland tissue. But it is a systemic disease and has many extraglandular manifestations. And so in trying to understand our overall mechanisms of Sjogren's, I was able to detect HDV antigen and sequence within about half of the Sjogren's patients, put that into mice, and the mice developed a similar phenotype to Sjogren's in vivo. So my lab studies HDV in Sjogren's patients quite extensively, but what becomes more challenging and why we need to have a better understanding of HDV epidemiology, and really why I started looking at HDV epidemiology, is that while we can detect HDV antigen and sequence within the salivary gland tissue of Sjogren's disease patients, there has been a lack of evidence of a current or past hepatitis B virus co-infection. So we're not really sure of how the patients are acquiring HDV within the salivary gland tissue. And so a recent publication, we again showed in a third patient cohort that about half of the patients have detectable HDV antigen. So here's HDV antigen detection, and some patients have quite a substantial amount of antigen within the salivary gland tissue. And then also looking at HDV RNA, we're seeing a nuclear localization, which may suggest that this is at least a low-level replicating virus within the salivary gland tissue. And so our hope is to better understand HDV epidemiology, to try to understand where Sjogren's patients are acquiring this, especially with the lack of an evident HBV co-infection. And so this is from our recent publication looking at the liver enzymes and markers for liver function. And what we're finding is that in patients, here's the total patient population, patients who are negative for HDV, who had a moderate level of HDV and a high level of HDV. And what we find is overall, there's not a strong liver phenotype in these patients. As well, going back in, some of these patients in a retrospective study, so some of these patients have been tested for HBV markers, but there's been no evidence or no positive tests for either HBsAg or HBC core antibody, or any type of prior diagnostic code, so ICD-9 or 10 within the patient records. So at this point, we really don't understand where the patients are acquiring HDV and how it's getting to the gland and causing disease in the absence of hepatitis B virus. So with that, I would like to acknowledge members of my lab, both current and past members, and specifically Matthew Hesterman, who was the first author on this study. Collaborators across the University of Utah, including Dr. Kisa Lynch in gastroenterology and hepatology, our collaborators looking at salivary gland oral pathology, Dr. Trump and Dr. Brewitt, as well as collaborators at the local health department and the local county health departments, and as well as always the funding agencies who have funded this research. And so with that, I would like to thank you for taking the time to listen to some of our findings looking at HDV epidemiology, and I will take any questions.
Thank you so much, Dr. Weller. This was a really wonderful presentation and fascinating insights, especially about the connection to Sjogren's disease and the lack of hepatitis B presence. So that's pretty amazing. And also, I think, it really underscores the need for reflex testing and updated ASLD guidelines as well. And hopefully, since hopefully greater availability of testing at different labs. I think LabCorp recently introduced an antibody test as well. So that will hopefully go a long way as well to increase. So I think we had 2 questions from the audience, which we can start with.
Okay.
So the first is, could you generalize a conclusion that we have a ratio of HDV among HBV patients as 1 to 8, or if there's any kind of conclusive statements we could draw about the prevalence rate as we know it?
I think the prevalence rate is interesting. So we were seeing an overall prevalence of 3.2, which is kind of matching what we saw in other publications. But when we go in and look at the actual HDV positive test is when we, to see who was tested and if they were positive, that's where we started to see the higher numbers. So at this point, I think we need to do larger cohorts, and we're working on that now to better understand the prevalence of this until we start testing more than 80% or more than, until we start testing more than the 20% we're currently testing. We really can't make an assumption just yet.
For sure, that makes sense. Yeah, I think the global prevalence rates right now, from what I see, range anywhere from 12 to 72 million. So really huge, huge gaps for sure.
Yeah, definitely.
And then I think the second question that we have is if there's any info you could provide about the prevalence rate in Africa or West Africa specifically, or if there's anything kind of known about the presence of Delta there.
I know there's been multiple publications, but off the top of my head, I don't know the prevalence rate. And I think anytime we do an evaluation of prevalence, we really have to think about also who we're testing, right? So is this a broad test, or is it within a specific patient population or a specific clinic that's looking at liver patients? And so until we really get more testing going on and even reflex testing in all Hep B patients, I think it's a little more challenging to really make those a definitive prevalence.
Yeah, absolutely. I think we still have quite a ways to go for sure. Let's see, we have another question. Could we consider hepatitis delta as an independent hepatitis B, I think independent from hepatitis B infection, which I think your research.
Yeah, so we're seeing that in Sjogren's patients. The level of the HDV in the Sjogren's disease patients is substantially lower than what we would see in a full HBV/HDV co-infection. And so, but I know other labs have shown that HDV can package into non-HBV viral particles. So there is the chance that if HDV is within a cell line, no matter how it got there, if there's another virus that comes through, there is a chance that it could be packaged and then transmitted with that other virus. And we're also seeing that in the HDV-like research where other viruses have been shown to package and transmit HDV-like sequences. And so I think that, how we test for HDV right now is we look for antibody and we look for sequence, but at no point does any of those tests say that it is specifically packaged within a Hep B particle. And so, there's always the chance that if HDV has picked up the ability to package in a non-HBV viral particle, that it's going to be challenging with our current tests to really differentiate those patients. And I think once we start tracking HDV epidemiology more, having more larger cohorts to really start to differentiate those patient populations, we can start to answer those questions.
Yeah, that's so fascinating. And so would it still, if it was packaged differently, would it still have similar impacts on the liver? Or
That
is
would really depend. Yeah, that's a great question. So that would really depend on the tropism of the virus. So right now, the tropism or what cells HDV gets into are really dictated by what cells are permissive for Hep B. And so if it's packaged into another virus, then it may be able to target different tissues. And so that's why we think potentially that HDV within the Sjogren's disease patients may be packaged within a different viral helper virus or more than one type of helper virus. And a lot of viruses pass through the salivary gland. So it may just be either a direct infection of the salivary gland or just passing through and kind of dropping it off on the way. But it's the tropism of where we're going to see these HDV in the absence of Hep B are really going to be dictated by, who it's hitching a ride with.
Yeah, that's amazing. Well, I look forward to your future research on that. Um, just some kind of questions that I had along the way. So I know, so you had mentioned that the tests were only performed in 22% of patients on the health
Mhm.
system. Was there any, besides the fact that maybe those patients had elevated liver enzymes, was there any other commonalities in why those particular tests were done?
At this point, with our smaller patient population, it was a little bit challenging to identify those, but we did see that at least in the HDV positive patients, we were seeing elevation of liver enzyme and liver markers that would suggest that they may have been more likely to be tested. And also, the patients who were coming in to be tested for HDV, they had a more extensive Hep B workup than we normally would see for the rest of the patient population. So that, to me, says that there's probably better linkage to care and that there were more investigations going on than we would see across the entire HBV patient population.
Okay, that makes sense. Absolutely. Um, I just have, if anyone else has any other questions, please feel free to put them either in the chat or the Q&A box. I just have a couple more that kind of
Okay.
arose during your presentation as well. Also, just in a similar vein, for um, the 55% when you evaluated the who was testing for hepatitis B throughout the country, and the 55% of states and territories where it was reportable, was there any kind of overarching trend in those places? But like were they more urban or maybe you didn't go this far,
No, we
but
didn't go that in depth, but
okay.
one of the things I continually heard when I would, because a lot of times you can't find that information online, it's not readily accessible. So I was on the phone calling all the different health departments and
Yeah.
really trying to get an understanding and to see if they've seen any changes in HDV epidemiology in recent years. More of my focus on Sjogren's.
Mhm.
But what I heard over and over again is we haven't seen a case in a long time, and so you always wonder if they're testing first off, and then if it's even if it is reportable on a state level, is that chain of reportability intact and being used, and so I think that there was just a lot of we don't know because it's so rare. So I'm hoping that the CSTE, the HDV case definition, will really help define which tests have to be run or
Mhm.
should be run, and maybe we'll open up those chains of making more states, more favorable to having it on the reportable list. I think if clinicians are seeing patients who maybe don't normally see hepatitis B or Delta patients, having that defined list of what you test for and readily available at the state level will really help define that, because I do see some patients just being tested for antibody to IgM. And if they've had this for a long time, if they've had the infection for a long time, that IgM antibody may or may not be there. So we may be missing missing a lot of those patients just based on selecting the inappropriate test. So
Yeah, 100%. I think those having the clearly defined definition and the requirements for reportability and notifiability will go a long way, hopefully. And
hopefully,
will hopefully end the kind of catch-22 that we're always in of not being able to make decisions because of not having data, but then not having any support to get data for health departments.
yes, yeah.
So that would be great. Um, All right. And then I think just my last sort of question, this may be something that you're also investigating as well, but it was interesting to notice the trends towards more female presenting with hepatitis delta and then younger age groups.
Mhm.
Um, and just any thoughts on why that might be, or it might be too early to tell.
Might be too early, but just hypothesis level. I would anticipate that if a patient is going to have complications and they do have a co-infection, they may present earlier
Mm,
than a standard, just a mono-infected HBV patient. And so we'll have to see if that trend is present in larger data sets or in other epidemiology studies in the United States. And then the female, obviously I study a female predominant disease, so I thought that was interesting. And I tend to try to look for those changes, but again, our data is just too thin currently within any individual healthcare system. And so using the larger, more aggregated healthcare record systems is really needed to see if we're seeing that shift. And those are the type of shifts we can start to see when we do have larger epidemiology data to work with. Is, what's changing in the patient demographics? Is this indicative of something else going on versus just maybe a change in transmission? So
yeah. Absolutely. Well, this is very exciting, and I think, poises for all kinds of very generative research going forward. So thank you so much for your
yes, thank
incredible
you.
work and for this presentation. I think, Shreya, if you wouldn't mind just putting up the last couple of slides that I have, please and thank you. Um, and so thank you so much again, Dr. Weller, and to everybody for joining today and participating in the webinar. And we hope that you found it informative and valuable to your work or your life going forward and can apply some of this information. I think we can move to the very last slide, if you don't mind. Thank you so much. So we encourage you to complete the evaluation form that should pop up on your screen when the webinar concludes. And again, a recording of the webinar will be emailed out to all participants and registrants. We also encourage you to sign up for our Hepatitis Delta newsletters. We have one for providers and also another for those living with or affected by hepatitis delta in order to be added to our mailing list and receive regular updates about things like drug development, clinical trials, research, news, and events like this one. So we'll send those links out in an email as well, along with a recording. And please don't hesitate to reach out to us and get in touch using the contact information on the slide. And you can always visit our website for more information about all things hepatitis delta. And Shreya has also put the links in the chat for the newsletters to sign up as well. Thank you so much. So I believe that concludes our webinar today. So thank you so much, everyone, for joining. And thank you, Dr. Weller. We really
Thank you.
appreciate your time and insights. All right, and have a wonderful rest of the day.
Thanks.
Bye.